Okay, I'd like to welcome all people that are in this meeting. G-ECHO is hosted by the Gastro Foundation in association with Project ECHO, University of New Mexico. And G-ECHO Fellows is run every Monday at 6 o'clock. And the chat will be open at the end of presentation. Muchi here will present his topic and will discuss at the end. It's an interactive presentation. Are you ready, Muchi?
Yes, Prof, I'm ready.
Okay, you can start sharing and presenting.
Sharing. Right. Good evening, colleagues. I'm Dr. Muchichwa, I'm GIT Fellow at Charlotte Matlete. I'll be presenting today on constipation, dyssnergic disorders, and fecal incontinence. All right, to start with, I'll just have a brief overview of the colon. As you can see here, the colon has got many parts, as we know, starting from the cecum, ascending colon, transverse colon, descending colon, and the rectosigmoid. Normally, about 1.2 to 1.5 liters of effluent passes through the ileocecal valve into the colon, of which most of the contents are reabsorbed in the ascending colon. By the time it reaches the descending colon, it's mainly formed feces to semi-formed feces and stored in the rectum. And what we excrete is probably around 200 mils to 400 mils per day. Primarily, the function of the colon is to absorb water, electrolytes, short-chain fatty acids, and also it helps in producing and absorbing vitamins and forming and propelling formed feces towards the rectum. Cross-section, having a look at the cross-section of the colon, normally from in out, we have the mucosa, then followed by the submucosa with a muscular layer, which is the inner one will be the secular, the outer one being the longitudinal muscles. After that, we have the serosa. Intertwined between these muscle layers are the enteric nervous system with the interstitial cells of Kajal, which is usually where the contraction of the colon usually originates, and they are modulated by the sympathetic and the parasympathetic nervous systems. As you can see here, the innervation is actually quite complex. Of note is that the external anal sphincter has got supply from the pudendal nerve. So with this understanding, we're going to move into constipation per se. I'm going to start by defining constipation. So this often relates to difficulties in defecation, which involves the infrequent bowel movements, hard or lumpy stools, often associated with excessive straining and sensation of incomplete evacuation or blockages. Also, use of manual maneuvers to facilitate evacuation forms the definition of constipation. And the time frame for chronic constipation that we look at is 3 months. Often when we meet patients, we do have to figure out what exactly do they mean about constipation. And some of the patients may have constipation referring only to hard stools, but when you do question them further, you may find out that excessive straining is also there, or sensation of incomplete evacuation is also there. That forms part of the definition of constipation. The prevalence of constipation varies quite widely from about 1% to about 80%, depending on the population that is being surveyed by multiple studies that I look at. But the average is around 16%. We know the risks with constipation increases with age, and some of the risk factors include female gender, depression, inactivity, low caloric intake, low socioeconomic status in form of income and educational status, and often side effects from medication, especially over-the-counter, some of the over-counter medication and prescription medication. Also, patients or people with physical and sexual abuse, they can present with constipation. When we look at constipation, we classify it into the primary or secondary constipation, for which primary constipation has got three entities. Number one will be the constipation with normal transit time, which often occurs in patients with functional constipation. We'll look into the ROM classification of functional GIT disorders, and then define functional constipation. Also, then number two, under the primary constipation, will be constipation with delayed transit times, whereby there is slow passage of contents through the intestines. This is often these disorders of the mesenteric plexus, as I highlighted on my slides earlier, and also sometimes with the neurotransmission. On the third, for primary constipation, will be anorectal dysfunction, which usually will be the dysfunction of the pelvic floor and the sphincter muscle. We're going to look later on, when we look at constipation, the anatomy of this pelvic floor. ROM4 functional gastrointestinal disorders of constipation is got four entities. It's got functional constipation, which is defined as, being constipated for more than 25% of defecation, and also fulfilling the definition of constipation that we alluded to earlier, which is straining, lumpy hard stools, sensation of incomplete evacuation, sensation of anorectal obstruction or blockages involving of manual maneuvers to facilitate evacuation. Also, these patients, they will need laxatives to pass stools often. And then we have irritable bowel syndrome with constipation, which is IBS with constipation. We often have to distinguish between these two, and the key distinction feature there will be pain. In IBS with constipation, they often have the pain decreases after the bowel movements or after passing flatus. Whereas in functional constipation, in addition to infrequent and difficult emptying, there is actually tension there. So that will be the distinction between these two often from clinical history. Number three on the ROM4 classification will be opioid-induced constipation, and then functional defecation disorders. Moving on to secondary constipation. Secondary constipation, the most commonest causes that we have to exclude from, especially from history and physical examination. Number one would be the use of medications. Most common used medication that causes constipation include tricyclics, which is antidepressants, anti-epileptics, and antipsychotics as well, calcium channel blockers, antispasmodics. Then mechanical obstruction can be from intrinsic, which is like colorectal malignancies, causing an obstruction, presenting with constipation, or it will be an extrinsic compression, like abdopelvic malignancies, not necessarily originating from the bowel. And also we can have constipation secondary to strictures and even large rectal cells as well. And patients also with anal fissures due to pain, they can present with constipation, not necessarily being mechanical. Other causes would be metabolic conditions, hypercalcemia, hypokalemia, hypomagnesemia, uremia, and also endocrine disorders like diabetes mellitus, hypothyroidism. When you look at these conditions, metabolic disorders and endocrine disorders, patients often will present with telltale features to suggest one or the other, and we have to investigate accordingly. Also, other causes are not so common would be myopathies, patients with amyloid, scleroderma. Also, when we look at these patients, they will have telltale clinical features to suggest these conditions, and we have to investigate accordingly. Neuropathies, patients with Parkinson's disease, patients with spinal cord tumors, patients with strokes, patients with MS, multiple sclerosis, do present also with constipation. Clinical history, physical examination also gives most of these key diagnoses away. Other conditions that we also have to look at, I alluded to them earlier, would be depression. Also, patients with degenerative joint disease may present with constipation. If you look at these patients, they may have issues with going to the toilet, squatting, and then subsequent to that, not able to pass stools. As we know, it may be actually very difficult to pass stool in standing position. Other secondary causes will be, cognitive dysfunction, patients who are immobile. That also will give away if patients do present with constipation. In terms of diagnosis, as I've been mentioning, history and physical examination, these are quite key in forming the diagnosis. And on that, we actually need to rule out existence of alarm symptoms and causes of secondary constipation. That's, the key part when we're obtaining the history. And in terms of alarming features, we're looking at age above 50 and patients with anemia, patients with GIT bleed, significant weight loss, palpable abdopelvic masses, and patients with family history of colorectal cancer. Also, when we look at patients with history or family history of inflammatory bowel disease. Key to the examination is the anorectal examination on its own. We can go a bit further in this aspect. When we do a rectal examination, first we have to inspect the perianal area. We are looking at what's obvious excoriations, what's obvious can be protruding masses. Sometimes you can see protruding hemorrhoids. We can see condylomata there as well. Many things we can see just on inspection. When we do palpate, when we put in a finger there, we're assessing for tone, we're assessing for masses in the rectum, assessing for tenderness, which may be a key clue for patients with anal fissures. Feel the consistency of the stools, hard, firm, soft, and constipation often is hard. And then you ask the patient to squeeze the finger ×2. You can, with experience, you can determine whether this squeeze is normal, it's weak, or it's actually increased. Ask the patient to bear down 2 efforts. So in this, we are really assessing for the push effort. We are assessing for sphincter relaxation and perianal descent, because this can give quite a clue in patients with defecation, with dyssnergia. Patients with dyssnergia, when you ask them to bear down, they may be unable to contract their abdominal muscles or to relax the anal sphincter when you ask them to contract. In actual fact, they may have a paradox anal contraction. We'll see later when you look at the anorectal manometry. And also, there will be sometimes absence of perianal descent when we do this rectal examination. So we can get quite detail in terms of in terms of diagnosis when you do a rectal examination. Actually, rectal examination was quite comparable to balloon expulsion test in terms of excluding or ruling in patients with dyssynergia. So after performing clinical examination, and we often go to do physiological testing, but to start with, what we have mostly at our disposal is colonoscopy, which will do patients above 45. In patients below 40, a sigmoidoscopy may be adequate, but full colonoscopy is advised if there are alarm symptoms, as alluded earlier. Then we also perform anorectal manometry. I have a slide on anorectal manometry, and also showing us the types of dyssynergia that we have. In terms of a balloon expulsion test, what we do is we put in the balloon in the rectum, inflate about 50 ml of water in it, ask the patient to pass the balloon in the chamber. We expect for the patients to expel the balloon within 60 seconds. Above 60 seconds, we call balloon expulsion time will be prolonged. And this has got a sensitivity and specificity of 88 and 89% in terms of detecting dyssynergia. And then also, in terms of evaluating our patients, we can use colonic transit times. Historically, we use radiopaque markers. How we do them is we discontinue laxatives 3 days prior to the test. And after 4 days of ingesting these radiopaque markers, we do X-rays. And then if there's 20% retention of the markers, the test is deemed positive. We do have delayed transit times. But of late, what's coming in is a wireless motility capsule. And also, then another modalities in terms of assessing this pelvic floor is a defecography, which we can use either a fluoroscopy or an MRI. And an MRI has got a benefit in terms of, because instead of only showing us the structures of the pelvis and the anorectum and the pelvic floor, it also enables us to visit surrounding structures, especially in the ovaries, uterus, and everything else. And also, it's got less ionizing radiation compared to fluoroscopy, but availability may depend with each centers. When you look at the anorectal manometry, what we tend to do there is to assess the internal and external anal sphincter. We also assess the rectal sensation and the anorectal reflex, as well as the rectal compliance. From this data, we are able to come up with 4 distinct types of dyssnergic disorders. Normally, when we do when we do assess this, a normal response will be when you have an increase, when you're passing stool or when you're defecating, you have an increase in the rectal pressure. With the subsequent simultaneous relaxation of the anal sphincter. So that's the normal physiology when we are defecating. However, in dyssynergia, you do have, in type 1, we have an increase in the rectal expulsion pressure. However, you have got a paradoxical increase in the anal sphincter pressure. And this leads to, you won't be able to empty your bowels in this case because you do have increased anal sphincter. And whereas in type 2, you don't have enough pressure generated in the rectum. At the same time, you have a paradoxical increase in the anal pressures as well. In type 3, you do have enough rectal pressures. However, there is less or no anal relaxation. In type 4, we have both no pressure in the rectum, and there is no relaxation or little relaxation, often referred as to less than 20% relaxation. So this is the usefulness of the anorectal manometry. We can gather this information. Once after gathering this information, we'll discuss later on the therapies that are appropriate for these patients. In terms of management of these patients, we have the non-operative and operative measures. From the non-operative, we do have what we do have a patient, we have to advise on lifestyle measures. Lifestyle measures that includes a high fiber or significant fiber intake, often referred as to 20 to 30 grams. Other texts will say 25 to 30 grams per day. And then you do advise adequate fluid intake, 1.5 to 2 liters per day. Advise physical activities, avoidance of food and medication that cause constipation. Once we have these failed, the lifestyle measures, then we move on to pharmacotherapy. In terms of pharmacotherapy, often we do use osmotic laxatives, which include lactulose versus polyethylene glycol. What these, they just draw water into the intestine and then facilitate rapid movement through or increase the transit time in the colon. And then we do also form the bulk. We do also have bulk forming agents, which also draws water in the colon. Then you can use stimulative laxatives like bisoconazole. Lately, there are secretory laxatives like lubiprostone, linaclotide, and plecanite. How these agents work is they act on the on the chloride channels in the large intestine. They're secreting chloride into the large intestine. Then sodium and water follows through just to maintain electrical. Usually sodium follows to maintain electrical neutralities. Once sodium comes in, water also comes in. Then we do have increased in bowel motion with these agents. Specific to opioid-induced constipation is methyl naltrexone. Surgical options for patients with constipation is usually reserved for patients that are refractory to both conservative treatment and medical treatment. What do we have available? You have a cecostomy, where you put a tube into the cecum and then you can connect it to, you can use normal saline with polyethylene glycol, then flushed into the cecum, then moves the bowel. You can do it once or on a regular basis per week. This often helps, but this is often employed in children. In terms of colectomies, you can do various surgical approaches where you can do a segmental colectomy with ileorectal anastomosis, or an ileosigmoid and cecorectal anastomosis, or you can actually do a proctocolectomy with an ileo anastomosis. But we have to remember that these surgical approaches, they are reserved for refractory cases. In terms of dyssnergic definition, it has to meet the ROM4 criteria, and it has to demonstrate a dyssnergic pattern of defecation, as I alluded to earlier on the manometric examination. And we should also have one other abnormal test, especially like a balloon expulsion or a prolonged colonic transit time, and an abnormal defecography, which is usually defined, if you use the barium, it would be like 50% retention of barium. Treatment of dyssnergic defecation. One importantly, as we alluded to earlier, also in patients with constipation, will be general measures, which include diet, fluids, exercise, and then use of laxative and prokinetics as well. But specific treatment for patients with dyssnergic defecation will be biofeedback therapy. I have a slide on biofeedback therapy when we can use it and basically how it works. We can also use cognitive behavioral therapy in these patients. Surgery also reserved for refractory cases where you can do a myectomy, success rate there, 30% improvement. Colostomy or colectomy is last resort. Moving on to fecal incontinence. Usually we define this as involuntary loss of solids and liquids, liquid feces. When it's anal incontinence, to differentiate between fecal and anal incontinence. Anal incontinence is when we have both solid or liquid incontinence plus flatus incontinence. And we usually also define it as edge incontinence when the desire to defecate is preserved, or passive incontinence when there's also lack of awareness that I need to pass through. And the risk factors for fecal incontinence include old age, diarrhea, fecal agency, also urinary incontinence, patients with diabetes, patients on hormone replacement therapy. If we look at the physiology of defecation, what happens usually we have stools coming down to the rectum. Then we have the distension of the rectum. If there is adequate sensation, we have relaxation of the internal anal sphincter. And then when you desire to defecate, what then happens is that you have got relaxation of the puborectalis muscles, which forms a sling in the rectum, maintaining this acute angle. This usually, forms key part of the competence of the rectum. So when this relaxes, the angle becomes less acute, more than 110 degrees, because the normal is 80 and 110. And also aided by squatting, we have straightening of here, and then you also have relaxation voluntarily of the external sphincter muscle. Then we do pass stools. So any disruption of these mechanisms will do cause any mechanical disruption of this mechanism causes fecal incontinence. We'll look at them later. But also continence depends on several key factors, which include the cognition that I need to pass through here, and then able to relax the puborectalis muscle, external sphincter muscle. If cognition is impaired, as we alluded to earlier, when patients with dementia, they may become incontinent. Also depends on the stool volumes and continence. If we have got large volumes of stool here, this mechanism may be overwhelmed, and then patient becomes incontinent. And also if there's a rapid colonic transit times as well, that may overwhelm our mechanisms. If you've got anal sphincter dysfunction involving either the internal anal sphincter or external anal sphincter, you have issues with your continence there as well. As well as anorectal sensation is quite key in terms of continence dependence. Causes of fecal incontinence. When we do look at it, we look at the, as I said, structural abnormalities. Key to that, as I said, is puborectalis muscles, if you have got damage to these, like especially in patients that may go into labor, obstructed labor, they can damage these. And also in pelvic surgeries, abdominal pelvic surgeries, they can damage these mechanisms, and that can cause incontinence. Also, patients with central nervous system issues, like spinal cord injuries, head injuries, strokes, yes, and back surgeries can have incontinence. In terms of functional abnormalities, when we do have impaired anorectal sensation as a result of obstetric injury or other insult to the central nervous system, or in patients with diabetes, they can come with incontinence. Then other causes of fecal incontinence that we have to be aware of: physical mobility, cognitive dysfunction. How do we approach a patient with fecal incontinence? Key to that, obtain detailed history, perform thorough physical examination, include digital rectal examination, and then once we exclude major issues, we do often proceed to do lower endoscopy in most patients, sigmoidoscopy for patients for less than 40 years or 45 years of age. Then we do on, if patients with diarrhea and coming in with incontinence, we do investigate for the possible etiologies of diarrhea before we move on to more specific tests. Endorectal ultrasound or MRI in patients with suspected sphincter disruption, recent surgery, recent obstructed labor, or just even a normal labor, but now presenting with fecal incontinence. We will go on to do this investigation. On the slide here, I do have a slide for like a normal ultrasound showing this will be the darker rim here will be your internal anal sphincter, and then the lighter, brighter one will be your external anal sphincter. So in this slide, I have a patient on abnormal endorectal ultrasound. As you can see here, there's disruption of the internal anal sphincter, as well as disruption in the external anal sphincter. This is taken from up to date. It was an example of a patient that had obstructed labor. So an ultrasound is actually quite sensitive in terms of evaluating these internal and external anal sphincter. However, MRI is, besides only telling us these, can also tell us further in terms of other pelvic issues. Then anorectal manometry can also be used in terms of evaluating patients with fecal incontinence. This will be giving us more details about the pelvic floor muscles, and as well as a difficography, as alluded to earlier in our slide, of constipation. So treatment for patients with fecal incontinence, number one is supportive. Fecal incontinence is quite distressful. Patients do need extensive psychosocial support. They have to avoid food and activities that makes incontinence worse. And then food and dietary symptoms as well. They have to take care of the perianal area. Perianal hygiene has to be improved. We can use barrier creams like zinc oxide. Also to use incontinent pads as well to try and, this is the supportive treatment we have to offer these patients. But key to that is psychosocial support. No specific medical therapy really that's benefit in patients with fecal incontinence, except when it's largely diarrhea, where antidiarrheals may actually help in this case. Also, there may be a role in bulking agents in patients with diarrheal fecal incontinence. Biofeedback has got also a role there, and surgical treatment will be repair for mechanical sphincter disruption, and also anal sphincterectomy in centers where these services are available, try to reconstruct. And patients may resort to actually colostomy or an ileostomy to divert stools, because where there you actually have more control of what's be going on compared to just passing stools uncontrollably. If having a look, we can have a look at the biofeedback. So here, what happens is we're trying to cognitively retrain the pelvic floor muscles and the abdominal wall muscles so that there is actually coordination. When patients do contract their abdomen, there will be actual relaxation of the anal sphincter compared to paradoxical or no relaxation of the anal sphincter. So this can be actually be achieved by this biofeedback therapy. But this often works to patients with intact anal sphincter and also to patients with edge incontinence or patients with decreased rectal sensation, as often determined by the manometry. However, it's not indicated where there is isolated internal anal sphincter weakness, or where there is overflow incontinence associated with behavioral or psychiatric disorders. Also, patients with neurological disorders, which we may need to address separately. Also, doesn't really work in patients with decreased rectal storage, and for those with major structural damage to the continence mechanisms, where repair may actually be of help. I do have a take-home messages for patients with constipation. The key there is good clinical history and physical examination. Exclude organic causes. Take cues to alarm symptoms. When we're managing them, general measures first, if we've excluded major issues. Assess for dyssnergic defecation in patients where general measures are not working. Once that is excluded, once a dyssnergic defecation is diagnosed, biofeedback therapy, once it's excluded, stepwise approach or stepwise use of laxative. Rarely, or where there is intractable constipation, consider surgical intervention. That is my last slide. Thank you.
All right, thanks, Muzi, for a well-extensive presentation. Can you go back to the slide that talks about primary constipation?
Okay, this one.
This one here. Yeah, I'm just a little bit worried that your history did not identify or tell me how to differentiate a normal pelvic floor abnormality or dyssynergia and a slow transit type of constipation, because you could do that on history. If you are not able to do that, you're going to do a lot of tests. Would you like to tell us in the history what will suggest which one? So slow transit constipation compared to pelvic floor problems that you mentioned, internal and what have you. Because you need to have that in the history so that you can know which direction you're going to go. Otherwise, you'll be doing all those tests that you wanted to do, isn't it?
To do.
Which will be a way forward.
So I know for certain patients, when you do a rectal examination, that patients with pelvic floor issues or dyssynergia, when you do put in fingers there, ask them to bear down. They do not, they have several issues. which you need two of them to make that diagnosis. They won't be able to contract the abdominal muscles, or when they do, there is a paradoxical increase in the anal sphincter tone.
Okay, but in the history?
In the history, specifically, I'm not sure there.
Okay, Barbara? Dr. Makumbi?
Hi, yes, hi, Prof.
Yes.
I'm thinking maybe evacuation, digital evacuation. I'm not sure, though. I think that's one of the things that you'd ask about on history.
Yeah, so you have correct, because in slow transit constipation, the effluent doesn't get there or gets there slowly. Therefore, your rectum adapts. So they do not have sensation that the rectum is full. If you think about it, for you to feel a sensation of pressure, it has to increase faster, isn't it? Whereas a slow transit, that's a slow process. In the lower, when you have defecation problems, the transit time is normal, but you cannot evacuate. So you load in the rectum all the time, and then you get stuff packed in there, and they go and do digital evacuation to differentiate the two. My second concern was that you confused, or you combined slow transit constipation with dyssnergia. What was that meant? Did you mean that, or you made a mistake?
No, they made a mistake there, because slow transit, because dyssnergia, we are dealing mainly with pelvic floor and sphincter muscle, and then slow transit, it's you could be dealing with issues of the myenteric plexus there, or the neurotransmitters in the colon.
Yes. Okay, and then my third issue, you were talking about bulking agents in general in all constipation. Would you use that in a patient with dyssnergia? And what's the problem with that, if any?
So when they have dyssnergia, if you use bulking agents, because the problem is not with the consistency, it's with the problem is with the coordination between the desire to defecate and actually not able to defecate.
Yeah, so they're bulked already. You want to bulk them some more?
No, you wouldn't want to bulk them there.
You wouldn't want to use those, isn't it?
Yes.
Okay, and then you spoke about faecal thing, cystostomy. Where did you say we're using it?
It's often used in pediatrics.
So we use it in adults also? But which type of constipation do we use it in? We do it endoscopically here. Everywhere, I think.
Pardon?
I'm saying that we do it endoscopically. Which constipation would it be indicated in? Which type of constipation?
In patients with slow transit constipation.
Yes, with a slow transit, not all of them, isn't it?
Not all of them. You wouldn't use it in a normal transit, because the issue is not with movement from the cecum to the rectum.
Yes. Okay, my last one then is the anal manometry. You said to testing both the internal and the external sphincter. So if you take the internal and external sphincter, which one is the predominant pressure contributor to the rectum? And what is the percentage?
I think I'll be guessing there. The external anal sphincter is voluntarily controlled. Yeah. So in voluntary mechanism, it will contribute a significant percent. I'm not sure about in terms of figures there.
Okay, Yusuf will tell us. Yusuf? Yusuf from Pretoria.
I'm not quite sure, Prof.
Okay, so your internal contributes 70%. Internal sphincter, which you cannot control, contributes 70% of the pressure of the rectum. And the external is only 30%.
30%.
So most of this dyssynergias, the problem is mainly the internal anal sphincter. Okay, can I open for discussion? Anybody wants to say anything? None? Is there any other contributors? Otherwise, I'll keep going. Okay, so now you
Hi, sure. I was sitting far from the computer, but good afternoon. Thank you, Prof.
Yes.
No, I was just saying in the old literature, but I think it's still applicable. This third type we used to refer to as obstructive, obstructive defecation, so that one can think of all these anatomical defects which have happened during life, especially during labor, or if there's something really happening there, maybe a tumor, because indeed patients who have delivered who have had difficult labor, would have had those rectoseals or things, or whereby they would have to use their fingers also to relieve themselves. So I was just saying, obstructive, one thinks in terms of history, if there has been any previous surgeries to the pelvis or any delayed labor, then one can really think of maybe obstructive defecation things, the third type.
Yeah, that's correct. Even the abuses, that's correct.
So thanks, Prof.
Okay, Mashiko, are you there?
Yes, I am. Hello.
Hello, Mashiko. What do you want to add something?
No, I thoroughly enjoyed the talk. Congratulations, Petudzai. I never get tired of hearing about constipation because it's such an important topic. And I thought he covered it very well. So thank you for that. I thoroughly enjoyed that. I was just wondering, I don't know if I missed it, just to follow on None's point about the role of defecography, especially when you're looking for structural lesions as a cause for the incontinence. I know he spoke about the anal endo-ultrasound, but I mean, a lot of centers don't have that. But a simple X-ray defecography can show you a lot in terms of structural or anatomical explanations for dyssynergy, fecal incontinence. So I don't know if I missed that or whether he did say that.
Okay, Mashiko, you're talking about the X-ray or the barium?
The X-ray.
X-ray. Okay. Yes. Yeah, that is correct, actually. That is very correct. Musi, do you want to say something there?
I'm not sure if I'm getting the question correct, because there is an X-ray there and then a barium defecography, and then that one I compared with the MRI defecography. But as Prof. Mashiko is saying, some other centers may not have specific tests. But in terms of the role of a plain abdominal X-rays, yes, if there is obstruction, we will be able to, make air fluid levels loaded, cecum. We can actually get useful information there with a plain abdopelvic X-ray.
Yes, that's correct. The other thing I didn't hear from you is bad toilet behavior, because that's another cause of constipation, especially among professionals, isn't it? How does that work now?
Bad,
terrible, right? Bad, terrible toilet behavior. So I'm sitting here, I'm doing exams, you're stressing me, I feel like I need to go to the loo, I hold on. Tomorrow, Yusuf comes, is the same problem. And the next day, Barbara is the same problem. Can that cause constipation? And if so, how does it do that? Isn't it management of constipation include education and training?
Yes, it does. But that often leads to transient constipation rather than chronic constipation. However, if there is persistent social stressors, it can actually lead to chronic constipation as well.
It does lead to chronic constipation. I wanted the mechanisms. It does lead to chronic constipation. The temporary one is not a problem. And it falls into one of those groups that we're defining, isn't it? Yes.
It becomes a slow transit.
It becomes a slow transit because remember your colon predominant function is to absorb. So your chloride secretory mechanism is quiet. It doesn't do anything unless stimulated. So if you're sitting for too long, everything is absorbed. You have solid stuff inside there that stays for long. The colon has that primary mechanism, primary contractions or peristalsis that helps to mix and improve absorption, which you cannot control. And it has the propulsive one. The propulsive one is the one that becomes paralyzed, where you find that the contraction due to acetylcholine proximal to the debris, and then nitric oxide beyond that pushes the stuff all along. Now, if you, in your profession, you stay like that for long, then you get a slow transit, isn't it? You agree with me, Muchi?
Yes, I do.
Okay. Yusuf, you want to argue with me?
No, Prof.
All right. Anybody wants to say anything?
Did you talk about radio-opaque markers? And what are their utility, if any? Petudzai? In the assessment?
Yes, I did speak about radio-opaque markers on this slide here when you are checking on the colonic transit time. So, you ingest these markers, discontinue laxatives like 3 days before. Then at day 4, you do the abdominal x-rays. And then when you see more than 20% retention of these markers, then what is deemed slow transit. However, with the advent of wireless capsules, wireless motility capsules that may supersede these radio-opaque markers.
What is the positive result?
Greater than 20% of markers at 4 days.
Isn't it 5 days?
I thought it's 5 days also.
5 days.
And also, the teaching used to be that if they are congregated in the pelvic region, that is suggestive of dyssynergy. But I think we've moved away from that because you can have a lot of false positive tests. So it may be suggestive, but it's definitely not diagnostic. Okay.
Anybody else? We've got 5 minutes.
Noni has his hand up.
Okay, Noni.
Oh, hi. Oh, thank you very much. This is interesting. But just a question. Was it a question or comment? I'm not sure.
Yeah.
It's just been my personal experience, so it's an anecdotal thing. How acceptable to the patients is this difficography, basically? Because I've sent 2 patients that never came back to me. I think they didn't like it. I don't know, what's your experience with this thing? Difficography.
Yeah. Was the indication correct?
I think I was just following the algorithm.
Because from the history and clinical examination, you should be able to see whether it's indicated or not. Most of those that abandon it are the ones that still have sensation at the bottom, and the stuff at the bottom works normal. But if they have stuff that's not coming out and makes them uncomfortable, they'll accept it. They will accept it.
Thanks.
Any other comment?
Yeah, None, from the radiologists, I've heard that it's a mixed bag. Some patients, by the time they present, they've sort of accepted that that's the test they have to do. Of course, other patients are embarrassed, but apparently the privacy is assured. Obviously, the odor is a different story. So it's a mixed bag. Some patients are fine, kind of. I guess they've surrendered at that stage. But I mean, you can imagine it's just an unpleasant experience.
Thanks.
Okay. Is there any other comment, Muchi?
No comment, Prof.
I can't see that.
Before you close, I just would like to say something, but when you're done. Thank you.
Oh, okay. Any other comments before we go on? Okay, I just hope you're going to, or before I close, Mashiko?
Yeah, do you want me to go?
You like to say your thing now because everybody's quiet.
I just want to say to the fellows, thank you so much for your hard work this year. We've come to the end of the first year of this pilot project. I think it's worked well, but obviously, I'll have to hear from you about how it's working and what we maybe can change. But remember, it's a 2-year cycle thing. So next year, you're starting the first quarter with hepatology, and then we will complete some of the GI topics. But we will have a feedback session early next year, just so that I can hear from you, your own experiences about this thing. But from my side, I enjoyed it. I learned a lot. And just to thank you for your commitment, I really do appreciate that. And I think everybody has put in an excellent effort in the topics that they were assigned. So I hope you have a good break and have time for yourselves to rest and time to spend with your families. And we'll see you next year, fresh and ready for the new year. Thank you so much. I really appreciate it.
Okay, that's not the closure. You can't leave. I still have to say something. First of all, okay, I would like to thank all the presenters, and thanks to ECHO and University of New Mexico and ECHO India team for the support. Feedback is available in the chat. And a recording will also be available on the Gastro Foundation website. And again, of course, we'd like to thank the Gastro Foundation, Muchichwa, and most of all, Karen, for being so enthusiastic and putting us in line for so many years. Okay, can we now close the meeting and say, those of you who are going to enjoy the holidays, except the fellows, please enjoy them, and we'll see you next year, ready for the next ECHO meetings. Okay, bye.
Bye.
Thanks, everyone. We start again on the 16th of January. And Isneem, if you're there, you're it. You're the first one. I'll speak to you again soon. Have lovely holidays, everyone. Bye.
Thank you. Thank you.
Bye. Thanks, Karen.
This was our time.